Hello, Psyche community, and welcome to today's webinar, The Role of Pharmacogenetic Testing in Psychiatry. Thank you for joining us today. I'm Dr. Nicole Negebauer, a medical science liaison for Otsuka Pharmaceutical Development and Commercialization. I'll be serving as the moderator and presenter for today's exciting discussion featuring Drs. Goldberg and Goldstone. So with that, I'm going to hand it over to our speakers. Dr. Goldberg, if you'd please get us started.
Well, thank you very much, Nicole, and thank you all for joining us today in this lively discussion that Lisa and I hope to share with you on pharmacogenetics and pharmacogenomics. So potential benefits and limitations of pharmacogenetic testing. We've kind of touched on these. Let's go to the next slide and get a little more into the data. So I'm going to speak to this. The ideal study in pharmacogenetic testing would randomize two groups of patients, one to get a protocol printout of the candidate genes and the combinatorial pharmacogenetics that will tell me if a patient's an ultra rapid metabolizer or a poor metabolizer, or what's called an intermediate metabolizer, which is normal for the pharmacokinetic SNPs. And then it'll also tell me if there are known variants in certain specific candidate genes. And rather than look at the colored page, which tells you, yellow, green, red, I rip that page off and I actually look at the results. Imagine if you ordered an SMA 20 and the chemist highlighted not just out of reference range values, but said, patients got a low white count, so therefore, start them on this drug. So rather than use this as kind of a quickie path to say what to do, look at the actual data. Now, an ideal study would do that, and it would take into account the non-hereditary, non-genetic factors that go into the myriad of outcomes in treatment for depression. So there have been a few studies. We're going to just review a couple of them quickly here. This is one of them. Talk about the pros and the cons of this study. This was published, I think in 2018, provides a meta-analysis of patients with depression. Let's have a look at what this showed. So the randomization here was a group of major depression patients who were either given treatment as usual, which is whatever you want, or pharmacogenetic testing. Who was doing the treating? It was pretty mixed. It was psychiatrists, internists, obstetricians, family practitioners. So a heterogeneous group of prescribers to start with. Have a look on the left. So remission rates. Well, what was the chance of getting into remission, which is really the goal of treatment, right? Refining it. If you got the protocol versus if you didn't. So have a look at 12 weeks. If you got treatment as usual, the remission rate was 13%. If you got pharmacogenetic testing, it was up to 35%. So it was a statistically significant difference. You were about 3.5 times more likely to reach remission if you got the testing than if you didn't, which is, I guess, a comfort. But when I look at these data, the first thing I think of is, oh my gosh, treatment as usual netted a 13% remission rate. I mean, that's awfully low. And if this was meant to be a representative sample of several hundred patients, I guess the first question is, gee, it's certainly better than treatment as usual, but what's wrong with treatment as usual? The usual placebo response in major depression is about 30–35%. So the pharmacogenetic testing gives us a remission rate that's about what we'd expect with the placebo response rate in a usual sample. It makes us wonder sort of who the patients were, what the usual treatment even was, which we don't know. On the right-hand side, we see response rates, which are better. And I think this is the silver lining of the study was we get a fairly whopping 73% response rate and a fairly 36% response rate with treatment as usual. There's no placebo here. So I guess the questions that stick out in my mind are, well, what was the actual treatment and what accounted for such a low remission rate to begin with? Last point about this study, back to safety. You'd expect that the patients that got the pharmacogenetic testing would have fewer adverse effects because the prescribers would have picked things that spared the P450 enzymes that were poor metabolizers and so on. And this study did not show a difference in adverse effects between the groups, which is a little bit counterintuitive. We're going to look at another study in just a second that was somewhat similar. So the very thing that we expect from pharmacogenetics in terms of safety, we're not seeing. Now, I alluded to this one a little earlier, so I'm going to go a little quick here. This methylene tetrahydrofolate reductase gene codes for the high or low active form of the enzyme that'll transport folic acid across your blood-brain barrier. If you happen to get the low activity variant, does that mean that you might be a good candidate for, let's call it, repletion with supplemental dietary L-methylfolate? This is the one study which looked at that question. Unfortunately, it was not a statistically significant difference. Does that mean, oh, well, good hypothesis, but didn't work? Possibly. It also may mean the sample size wasn't big enough to pick up a difference. It really begs the question and leaves it open-ended. That is, to what extent might somebody who's the low activity variant of this MTHFR gene be a candidate for L-methylfolate? This is the one randomized study in the literature. It does not support, in an evidence-based fashion, routinely repleting L-methylfolate. So if one is an aficionado of using that intervention for depression, feel free. If you'd like to get pharmacogenetic testing to see if somebody happens to be the TT variant, where you have this lower activity form, again, feel free. It follows a logic. It's just we don't have an empirical evidence base as yet to support it, which to my mind means we need more research.
Thank you, Dr. Goldberg. So as I've already alluded to, there are a number of medications out there that do have labeling about dose adjustments that are needed based on your pharmacogenetic testing. So here you could see drug classes. I do want to point out to you, though, that it's not a drug class effect. You have to look at the individual medications within those drug classes. So this might be an area where there may be some utility in terms of dose adjustments, and especially if you're looking at other drug interactions that are also metabolized by those particular enzymes. So as Dr. Goldberg has already talked about a little bit, is the clinical use of pharmacogenetic testing, although it's promising, it's generally not currently recommended. And that's because of just insufficient evidence. And I do agree. And that's something you see even in our clinical practice, is we're not testing every single patient that comes in the door. And I think, you know, there is promise, but we definitely need more evidence to really see what the effects are. One thing you will notice, so I want to draw your attention to the ACNP statement that they don't recommend direct-to-consumer use either. And I think that's kind of one place where we have to figure out what we're going to do, because sometimes we would have patients who already had pharmacogenetic testing. Not that we would have recommended they do that, but now the patient shows up and they have this testing. And so I think it's really important, even if it's not something that you're ordering or recommending, you have to be prepared that the patient may come in the door, and you have to be able to understand the studies so you can explain those to your patients so they understand too. So I will turn it back over to Dr. Goldberg.
Yeah, picking up on that very point. So there was a famous case published in one of the journals a couple of years ago about a patient with schizophrenia that was an inpatient, and the inpatient team had a particular idea of how they wanted to treat the patient. The patient's family came in with waiving the pharmacogenetic testing and said, hey, the medicine you want to give our loved one is not on the list, so we don't want you to do that. And they actually got into quite a to-do and had to bring the ethics committee in. And ultimately, the treaters were able to say, the genetic test is one piece of data. However, the medicine we have in mind is a very powerful one, and we really think that it'll work, and ultimately the patient got better. So the pharmacogenetic testing is not the last word on anything. It's just one more piece of data.